Good morning, everyone. It's a real pleasure to welcome you in this CaRe online symposium. Obviously, we would have preferred to, to see you live and to see all your faces, but we are very glad that you're participating in this online CaRe symposium. Unfortunately, we had to cancel the CaRe Days of 2020, which was originally planned for last week. We had developed a beautiful program together with CaRe directors and with the board of CaRe, with magnificent input from the PhD representatives of the 4 institutes. And the title of that program that we originally planned was Illusion or Reality, the Influence of Our Mind on Research and Practice. Unfortunately, the coronavirus was not an illusion, but it is a reality that we have to face nowadays. The good news, however, is that the original program that we developed will be postponed for 1 year. So all the speakers that confirmed to participate in the program that we planned for this year will also participate next year. So we are planning to have the CaRe Days of 2021 during May, and all of them will participate. For this year, we decided to have an online symposium. And we realized that you are you're facing your screen during several hours a day. So we said we don't want to make this symposium too long. So we planned a 90 minutes symposium. And we would like to have it as interactive as possible, as long as the technique allows us. So what we would like to do is that you are really participating in this program and actively contributing to this program. If you look on your screen, then you see your YouTube screen. You see on the right side, you see a chat function called Top Chat. And you can use that function and you can type your questions or your comments. Input is more than welcome. But we have a request. We would like to ask you during the presentations that you do not give your comments, but give them afterwards. We will have enough time for discussions. So first of all, we are going to listen to a keynote given by Professor Jochen Kals. Jochen is Professor of General Practice. He is General Practitioner. And he is in the midst of all these corona things. He will give first a speak, then we will have the CaRe Award. Maybe, if the camera allows us, maybe you can see the CaRe Award already standing over there. It is the CaRe Award of 2020, and it will be granted to the PhD researchers who defended the best thesis of 2019. But first of all, we're going to listen to Jochen, and Jochen will give a keynote speech which is called COVID-19 registrations in general practice in the Netherlands. Jochen, the floor is yours.
Thank you very much, Onno, and welcome. Good morning, everyone. Most probably everyone is at home, sitting in front of his laptop or computer. I hope you have a nice coffee. We're sitting here in the studio in Maastricht, and thank you for inviting me. I've been on previous CaRe courses and seminars, and I wasn't expecting to be giving a keynote this year because the theme was totally different than COVID. But I'd like to tell you something about our project, which we initiated actually amidst the COVID pandemic, which occurred in the Netherlands from March onwards. My presentation will be in English. There will be some Dutch video clips and sometimes also perhaps a Dutch headline of a newspaper. I hope you will understand. I think that most of the audience is Dutch native speaking, but I'll try to explain for all the others, of course. I'm looking forward to the comments in the Tops chat, of course. If there's anything you'd like to ask me afterwards or during the presentation, you can always reach me on my email or, of course, on my Twitter handle, to keep it as interactive as possible. To be honest, before COVID, my research line on diagnostic testing was pretty active, not specifically, of course, on COVID, mostly on diagnostic testing, infectious diseases, acute conditions. But this project, which I'll be telling you about, is an example of, let's say, problem which we faced in general practice and which we made into a large national project within a few weeks. My general practice itself is in Sittard, which is 20 kilometers from Maastricht, and as you might have read, in February there was an outbreak just over the border of Germany, Heinsberg, where COVID occurred for the first time in Germany. As you may know, Gangelt is only a few kilometers away. Lots of my patients live there, so we were anticipating to have an outbreak in Sittard as well. It took a while until at least we found the first one, but the first patient I think in Limburg was also in Sittard. But Carnival, for instance, happened both in Germany and in the Netherlands. But within a few weeks' time, our practice totally changed, as you've seen in the news. This is me doing our what we call our Corona consultations in our practice, and we're still doing them now at the end of the day, although luckily it's much less patients at present. One of the things which struck me most in the early weeks is that all the emphasis, especially in the media, was on intensive care beds, which is very understandable because very important, and there was a lot of pressure on the hospitals. But most of the news, I would say nearly 90% of the news, dealt with intensive care beds and hospital resources. Nonetheless, we saw a lot of patients in our general practice, of course, and also in the care homes. So as you see here, these are the graphs, I think, of the beginning of April, graphs of Stichting NICE, which displays the ICU beds, and also our NOS slides giving us hospital admissions per day and also reported deaths per day. These figures were all based on patients who were tested for COVID. And as you might remember, especially in the early days, there were some lack of resources in testing, so that means that everybody in hospital got tested, but outside of hospital only limited patients could be tested. So coming back to my own practice, the first outbreak was in an elderly care home in Sittard, where a few patients got infected with COVID-19. Some of them died as well. And me and my colleagues had some patients in that same elderly home as well. And one of the things which struck us is that we came to one of the most hard-hit departments there, where a few of our patients got COVID-19, at least clinically. And a man and a wife both got very sick, especially the man. In the end, this patient of mine didn't make it, so he died. I called the public health services to report it because COVID-19 is one of the infectious diseases you have to report. But the public health services told us that although of course of interest, this patient wouldn't be counted towards the total amount of COVID-related death because he wasn't tested. No microbiological confirmation of the disease. So I called back and asked what the exact, let's say, strategy within the elderly care home was. And they said, well, we test 3 positives per department, and if it's 3, we think there's an outbreak, so we stop testing. And mind you, this is the beginning of March, of course. I mean, that wouldn't be understandable nowadays, but it's the beginning of March. So within that department where we had our patients, we didn't have patient 1, 2, or 3, but we had patients, I think, 5 and 6. And one of them died, so didn't count towards, let's say, the total amount of COVID-related deaths. Whereas this patient specifically had a very typical clinical picture of COVID-19, which we later described in one of the clinical lessons in the Nederlandse Tijdschrift voor Geneeskunde. Now, these let's say, rumors, and also these a lot of GPs, especially in Brabant and Limburg, saw the same thing. So this is a newspaper article of March 26th, where doctors in Brabant said, well, we see much more patients dying than we see back in our figures every day. And I was walking around with the idea, and then I decided to text one of my colleagues in Zwolle, Marco Blanker, who's at the Department of General Practice at the University of Groningen, to let's say to talk about an idea I had. During that telephone conversation, we decided to see if we can turn that anecdotal evidence, which we saw in our own practices in Brabant and Limburg and also in other parts of the country, into, let's say, a national overview, what happens in general practice, because all the emphasis was on the intensive care beds and the hospitals, whereas we thought that especially the doctors in the south were working very, very, very hard, also in patients who didn't go to hospital for understandable reasons. But we didn't know the magnitude of the problem. So we thought, how can we actually set up a registry and a national registry, and how can we set it up fast? So we decided on some research questions, and we wanted to know what a non-PCR tested COVID-19 clinically suspected death would be in the Netherlands, so the number, but also the geographical spread, of course, because we already knew that it was very unevenly balanced. But we also were interested in, let's say, how many patients do we actually leave at home? And I mean, leave at home, not a healthy person, not going to a hospital with COVID-19, but people deciding not to go to hospital anymore, so indefinitely, whatever the outcome may be. And the outcome, of course, in COVID-19 could be a patient could recover, but a patient can also actually die, of course. So we wanted to look at frailty scores. So what's the frailty score of a patient when deciding not to go to hospital? Also about the conversation the GP has with this patient, and of course we had some extra questions about palliative measures and also about the availability of personal protective equipment. At that time, very, very much a problem, especially in general practice and also in the nursing homes. So we wanted to show the role of general practice in the pandemic and gain knowledge to inform our own physicians as well. So having said that, of course, in a normal research project, you probably take about a year to write a funding proposal and then may be allowed to start or not. We didn't have that time. So we decided to set up a small team, and now I'll switch my slides in the sense that the background will change, because previous slides were from Maastricht University, but this is a consortium onderzoek huisartsgeneeskunde, so a consortium research in general practice. Together with Marco Blanker in Groningen, I'm coordinating that, and actually it is a collaboration of all the 8 departments of general practice in our country, together and supported by our Dutch Society for General Practitioners and NIVEL. And it was initiated in 2013, has been headed by Hans van der Wouden for quite a few years, very successfully. And it's a consortium which is focused on doing research projects together, larger studies. And one of the key items within the consortium is that if you need 3 university or 3 departments or more to run a study, a large clinical study in general practice, that's when the consortium kicks in. So we aimed to professionalize that this year, and we took actually this COVID-19 project to kind of speed this up. So as you see, there's a logo now, there's a website now. So we took the opportunity to speed up the development of the consortium as well. We asked the other departments of general practice whether they wanted to participate and support the idea of, let's say, setting up a national registry. And I think I'm very proud to say that within 24 hours, everybody agreed to work on this together. Then we thought about how can we actually achieve this, because building a new system would be very much impossible. So we approached Zorgdomein, and for those who are not familiar with that, Zorgdomein is let's say, a platform which 90% of the GPs use for referral letters. So if somebody is being referred to surgery in hospital or to a physiotherapist, this is let's say, the digital platform where the GP can put in all your information and it's being delivered at the hospital. And we thought, I had been in contact with them previously, and I thought they might be able to build something which we could use to register these COVID-19 patients. And so I approached them. And from that moment onwards, the CEO was very enthusiastic. They also wanted to contribute to this crisis and also wanted to play a role. So we set up a collaboration, so a public-private collaboration, so or less. And within 1 or 2 days, we had a team up and running. And they actually dedicated a full, let's say, content platform team to help us develop this on their platform, to which 90% of the GPs had their access. So there's an orange button there in the screen, which you can see, and that's more or less the button which they built. And of course, after the button, there's the registration form. So what we did, we aimed to have it up and running within 2 weeks, and we had a very small but very dedicated team of, let's say, academics, non-academics, clinicians, non-clinicians, junior and senior people, which I'd like to thank at the end of this presentation, of course. And we had to decide on the content, so prioritize the items to be included in the registration, but also, of course, look at all the graphical and content development of the platform. We had to get it through ethics, and that happened, or that succeeded within 2 days, I think, here in Maastricht, which was very nice. They had a speed procedure for COVID proposals, which was good. Of course, we wanted to aim to have it non-BMO-plichtig, also not to be forced to go through full ethics. So that means that we have anonymous data, so we can't go back to the patient. And of course, we wanted to involve all the stakeholders, and importantly, we wanted to share the information with our GPs. There's about 10,000 GPs in this country, and they were very, very, very busy at the time. Everybody was focusing on COVID, but running their practice. So we thought we could ask them to register patients, but we couldn't ask them to participate in long-standing research, which took them a lot of time. So we thought that the registrations had to be kept very, very minimal in time. So we also made a media strategy, or a strategy to get it into the public, and also to inform GPs and physicians, of course. And I think that was one of the successful parts of the study. And in the end, we succeeded to have it up and running in 2 weeks. And this is at least let's say, the call to action which we could send to GPs.
Er is veel aandacht voor COVID-19-patiënten in de ziekenhuizen, maar een overzicht van de intensieve en palliatieve huisartsenzorg ontbreekt. De 8 universitaire vakgroepen huisartsgeneeskunde willen dit beter in kaart brengen. Daarom is er nu in zorgdomein een aparte COVID-19-meldknop. Hiermee kunt u de COVID-19-patiënten melden die niet meer worden ingestuurd naar het ziekenhuis. Ook reeds overleden patiënten met en zonder PCR-diagnose kunnen hier worden gemeld. Zo brengen we samen de intensieve coronazorg die huisartsen leveren goed in beeld. En maken we de landelijke cijfers echt compleet. Het invullen kost minder dan een minuut en de knop vindt u links onderin het scherm in zorgdomein.
So before going to the results, which I'll show you on how many death and palliative cases we found, we used Mark van der Linden, our PR officer of Maastricht University, to help us in handling the media. We also had contact with parliament members who actually asked questions in parliament about death contributed to COVID-19 not being counted, and that helped us to set it up as well. And the NOS, our news agency, also made a short report on it, which was viewed, I think, 500,000 times, which helped us to actually kick it off. I'll show you that for 1 minute, and then we'll go back to the results.
Ze worden ook wel de onzichtbare coronadoden genoemd. Mensen die de afgelopen tijd zijn overleden, maar niet onder het kopje corona in de boeken kwamen, omdat ze ongetest en buiten het ziekenhuis stierven. Maar ze zijn er dus wel.
Vermoedelijk zijn er door het coronavirus in Nederland 2 keer zoveel mensen overleden, vooral ouderen.
Die thuis of in een verpleeghuis achter gesloten deuren overlijden, met symptomen die wel verdacht veel lijken op corona. Senna ziet de ouderen die zij al jaren verzorgt 1 voor 1 doodgaan.
Nu overlijden ze en dan worden ze opgehaald en dat was het. Elke dag dat je denkt van, oh weet je, dit was het, dan komen er per dag weer 2 bij.
Dus zeggen huisartsen:
Als we de totale impact van deze ziekte in kaart willen brengen, dan kunnen we niet anders dan ook zicht hebben op de patiënten die niet zijn getest.
maar hoe doe je dat? Het RIVM rapporteert alleen de doden die ook officieel, dus getest, aan corona zijn overleden. En dat is onvolledig. Daarom krijgen ze nu hulp van huisartsen en het Centraal Bureau voor de Statistiek. Omdat zij met hun eigen ogen kunnen zien wat er met hun patiënten gebeurt en zij zicht hebben op alle overlijdens in Nederland. Dat leggen we uit.
These video tutorials are very much a lot viewed by the NOS, and we kicked off our platform, I think, on April the 12th, just after Easter, and we asked GPs to register their clinically suspected COVID-19 deaths, but also the PCR-proven COVID-19 death, which they actually supervised or helped at home, so not within the hospitals. But we also asked them to register the patients who actually they provided intensive care to at home, meaning mostly people being bedbound, being in elderly care homes, not being fit enough to go to a hospital anymore. And so the system was open on March the 12th. We just analyzed the results until, I think, last Thursday. And as you see, we had about nearly 3,000 registrations. And this map clearly shows you all the hotspots which are within conformity of the RIVM maps, of course, with Brabant, Limburg and Gelderland being the hotspots. In total, GPs reported nearly 2,000 COVID-19 deaths. Mind you, that's a combination of tested and non-tested people. I'll show you the split in a second. And more than 1,000, let's say, palliative care trajectories for elderly patients or vulnerable patients, I must say. If we look at regional differences, of course, there's large regional differences. The north of the Netherlands here, what you can see, there's hardly any cases at all. Whereas in Brabant, Limburg, etc., there's even within some regions hundreds of cases. Within 3 weeks, we had more than 1,000 practices actually registering patients on the platform for COVID-19. But of course, there's differential registration. As you can see in the north, there's only a few percent of practices actually reporting cases, whereas in Brabant and Limburg, I think that's approaching more than 50% now. So I think the numbers we can present are still an underestimation of the actual numbers, but quite valid. We just inserted a new button where actually practices can register that they don't have any cases of this kind in their practice, which will help us to, let's say, to ensure the validity of our findings. Now, going to the, let's say, the number of deaths was heavily picked up in the media a few weeks ago, and this is the current standing, and luckily the curve is going the right way, of course. At present, we have 982 COVID clinically suspected deaths. So these are patients who are not tested by PCR, and these can be added up to the, let's say, the total number, which I think the RIVM publishes daily. And last week there were 5,871 COVID-tested deaths by the RIVM, and the nursing homes have their own registry. So people in nursing homes in the Netherlands, so long care homes, they don't have a GP, they have a nursing physician. So these 1,800 must be added towards that as well. Now, of course, we could also look at, as you can see here in time, in week number, you can see that actually GPs saw a lot more deaths which were untested at home than tested in the beginning. And as you can see, over time, that diminishes. So over time, we all know that testing procedures have been expanded. So now we see that nearly all patients are tested in general, but also those who actually die at home. So as you can see, the curve is similar to the RIVM curve, luckily. So beginning of April was most heavily affected period, and What can we learn? Well, it's a very old cohort of people with a median of 85 years. For those who die of COVID-19 at home, we have a symptom onset to end of life of a mean of 8 days, which is in line with what we see in hospital, that people might deteriorate after a week. The majority of people live in elderly care homes, and we had some measurements on supportive care measures at home, like oxygen. 90% of patients receives oxygen at home, and the other two are medications which you provide at end of life care. Coming to the end, we looked at vulnerability, because the clinical frailty score was used to guide physicians on can actually people survive intensive care treatment in hospital, and we see that the majority of patients who actually stayed at home was very vulnerable. And we also looked at reasons for not going to hospital, and of course this adds up to more than 100%, because of course there can be more reasons that a patient decides with their GP not to go to hospital. And as you can see the reasons here. It can be vulnerability, but there were also some advanced care directives, meaning a wilsverklaring, so people actually having something on paper already that they don't want any supportive measures anymore, not going to hospital, for instance. So this helps our physicians as well to at least have an overview of what happens in our country in these decisions. Well, reflections. We set up this national registry in a very fast, I would say, pressure cooking research project. I think that has risks, of course, of failure. We set it up without any funding. At present, we don't have any publications, because we set it up mainly to inform our own physicians in our country, and to guide them through this pandemic. Of course, we will be aiming to publish it at some point. We had a public-private collaboration within 2 days with a company which collaborated in a very, very constructive way with our Department of General Practice. And I think one of the things I took from this, well, let's say, challenge or adventure is that the multidisciplinary team of ICT people, clinicians, but also the press officers, for instance, everybody played their role, and everybody was very, very much constructive to let's say, show the contribution of general practice in COVID-19 at present. So I think that was very good, and I would like to challenge everyone to also at home, when you're not at the department, to sometimes just send somebody an app to have an idea and to talk over coffee or over Zoom, perhaps. And of course, this is not my work, this is our work, and I'd like to thank everyone who was involved. And there's probably some people who I forgot, but thank you very much.
Well, thank you so much. We cannot applaud Jochen with many people, but thanks for your really excellent presentation. And also, it's amazing what you have done, what you have accomplished together with all GPs in the Netherlands in 2 weeks' time to get it off and running. It's beautiful that what you have done. I would like to ask you again, if you have any questions, please write them down in the top chat function. You can use the top chat function, and Annarika here in the studio will help to record those questions. So maybe I could kick off, Jochen. It is amazing what you have done in such a short time. If you would go to the next, let's say, if we would have a next wave, what have you learned from this research, and what would you do different? Or would you do it exactly in the same way?
Well, I think hopefully in the next wave, to be honest, I think one of the...
Or don't we need it anymore?
Well, one of the reasons we set up this registry, because we, as a profession, thought it's not valid to only have those people tested in hospital, mostly in hospital, in the numbers, and we also wanted to provide focus on general practice, and I think that's something which happened over the weeks. Alongside the nursing homes, they did the same procedure more or less, saying, well, we need help as well. So I think hopefully in a second wave, or even within a few weeks, let's say the registry as it is now won't be necessary anymore, because the testing procedures are much wider, and we also, well, at least gain some knowledge, especially in Brabant, Limburg, about palliative care, etc., for these patients. So I think we live and learn, but it's I'm quite sure there will be lots of research in the second wave. But perhaps this registry isn't necessary anymore, but perhaps in another form, because as we know now that physicians in the north of the country, they haven't faced it at all. So I think we need to bring the knowledge of Brabant and the physicians there to other places if there's a second wave there.
So we can use it for COVID-21, but probably not for COVID-19 anymore, because it's not needed anymore. That's what you're saying. Are there any questions?
No,
Anne?
not yet. I just asked the audience if there are any questions. So.
Okay. Is it maybe one other question, Johan, and that's a question related to the diagnosis, because obviously it is non-confirmed, COVID. What are your estimations? How many of them do you think are false positive?
I mean,
Could you have
of course, there's a risk that there's under and over diagnosis within that group of non-confirmed, so non-microbiological confirmed COVID. I think that if you ask colleagues who have seen it a lot, they don't have a lot of clinical doubt. It's a very specific clinical picture, where especially with the low oxygen levels, we see sometimes, you see oxygen levels of 75, 80 in persons who are normally sitting there, which we've never faced before. So one of the gimmicks nowadays is that your oxygen saturation measurement device isn't broken, because if you go there, you think it's broken. So that's very specific. We do see that in the elderly, it can be very atypical, but we also saw that within those non-confirmed cases, there was in 50% of the cases, there was somebody living in the house with a confirmed case.
I see.
So like influenza, of course, it's very contagious. So that means also that if there's an outbreak in a nursing home or an elderly care home,
almost sure.
I think that of course there's always under and over diagnosis, but even with the PCR tests, we also have some false negatives, etc. So I think the clinical picture is quite clear. Although I must say we were quite lucky, of course, that influenza and all the normally respiratory tract infections went away with the spring and the summer. I mean, if this would happen in autumn or the winter, I think it would be much harder.
Yeah. Okay. Enrique, no questions? Now, I think then it is time to switch over to our next topic. Thank you so much, Johan. Please stay here, because you are really a COVID expert, and we are going to talk about COVID as well in the last part of our session. So we will now move on, and we will going to listen to Professor Chris van Weel. He is not in the studio, but he is at home, and Chris is appointed as the chair of the board of CaRe, and he is also the chair of the jury of the CaRe Award of 2020. And Chris, I can see we have connection with you, so we are going to listen to you. The floor is yours, Chris.
Thank you very much, Onno, and I'll go and switch on my slides. And if this is working, and I think it's working, thank you very much. Ladies and gentlemen, one of the great pleasures of the annual CaRe days is that we as board of directors are able to present the winner of the CaRe prize. And unfortunately this year we have to do it this way, but let's make the best of what is possible. And I see that I have to go back to my first slide, sorry for that. This year the award was awarded to the best thesis defended in one of the 4 institutes of CaRe in the previous year, in 2019. Each of the institutes nominated their top 3 PhDs, and as a jury, we really had to look at the very best of the very best research in care. Excellence in science, of course, was an important feature of the award-winning thesis: scientific originality, quality, methodology. But I've taken here the early publication we made through CaRe. Societal impact is as much an issue in the field of applied health research. So excellence in realized impact on practice, that is prevention, care for patients in primary care, in hospital care, or prevention and care for populations and groups, or in health services. Societal impact realized through research is an important feature, so that was an important part of our criteria as well. And from our assessment of the 12 PhDs we awarded we assessed this year, we had 2 observations to make we would like to present here as well. Most of the studies are multidisciplinary, and most of the studies realize a societal impact. But in many of the PhDs, the realized impact is pretty implicitly available. And we would very much like to see a more explicit, a better articulation of what the multidisciplinary nature of the research has been, and a better articulation of what, in fact, this study has added to the practice for individuals and for populations. So hopefully that is something that we will see back in the PhDs in next year. For this year, again, the jury was impressed by the high quality of research produced by CaRe, and we see this every year. So CaRe is able to produce high quality research over many, many years, and that is something that is most reassuring. Of course, we had 12 excellent studies, but there are 4 we would like to mention in particular. One was a study by Marion de Jong, who studied the home monitoring of patients with disease of Crohn or colitis ulcerosa, which was a very original, strong methodology combining clinical reasoning and ICT technology. It connected hospital care and home care, another important innovation for patient care. Another study was by Erika Maurits, a completely different field, and this demonstrates the broadness of the field of research in care. Erika Maurits studied autonomy of nurses in home care, and that study was particularly interesting because it was a very strong theory-driven research with carefully exploring the concept of autonomy in nursing. It had a high societal impact that the current COVID-19 crisis has made us probably even more aware of how important it is that we have a robust nursing staff available in care for people at home. But there were 2 theses that really stood out, and therefore we have a dual winners of the 2020 CaRe Award. The first is a study of Nina Barteling, who evaluated health promotion in complex adaptive school systems, the healthy primary school of the future. This was a study that was very strong in its methods, in optimizing the possibilities that daily school routines made it possible to run a controlled design. It used a very broad range of measures with respect to the healthy living. And this study really stood out in the details in which it reviewed its realized societal impact. So Nina Bartelink, I would like to congratulate as the first of the two winners of this year. And the second is the study by Eva van der Meij, who studied improving post-operative recovery through e-health. This was a hypothesis-driven study, and what stood out in this study was a careful exploration of the hypotheses the study was going to test. And as a consequence of a very thoughtful reflection on the hypothesis, it was possible to confirm rather than to refute the hypothesis. And as a consequence, this was a study that had a very high societal impact for the care of post-operative patients and again, combining primary care, secondary care. So Eva van der Meij as the second winner. And unfortunately, we're unable to raise the glass here or to applaud, but I hope we all award these two winners and we congratulate them on behalf of every researcher in CaRe. Thank you very much.
Yeah, it is always an incredible job by the jury to read those many PhD theses. So thank you to all the members of the jury, the board members of CaRe for doing this. And also I would like to congratulate Eva van der Meij and Nina Bartelink. Unfortunately, they are not here in the studio, and we are eagerly waiting to have a possibility to congratulate them. You see here on my desk, you see the two documents by which we would like to congratulate them, and also the two statues. So apart from that, both candidates will receive a prize of 500 euros. So this gives us a little bit more time to come back on the former topic that we discussed, because there were still a few questions left, and Jochen, so we didn't know that those questions came in, but now we have a little bit, we have, let's say, some 5 minutes time to go a little bit more into detail, and you have received some questions.
Yeah, so in this
Please,
digital area, I received them on paper. I think there was a little bit of a delay on the line on YouTube. There's a few questions what came in, so I'll try to answer them. What I received from Ayla Touran, I was wondering what kind of data did you collect on the patients apart from whether they died on COVID, and what kind of privacy considerations did you face? I think the latter is very interesting because, of course, privacy issues are play a role, especially if whatever research you do. We had to make sure that the data we collected on patients weren't traceable anymore to that specific patient, which is difficult also in times of COVID, because of course if a patient dies in a very small town and there's only one, you can still trace them back in your data set, etc. So that meant that we had to, for instance, if we the data we got on geographical location wasn't based on municipality, but we could only base that on the first 2 digits of the zip code. Mm-hmm. So that means we had about 90 areas in the country where patients could be, and that made the AVG committee and the METC committee allow us to do this type of research. So
they did it in 2 days' time. Eh? That's incredible.
Yeah, I think many academic hospitals have their COVID committees, mm-hmm. or at least their fast track. And of course, there's a difference between niet-WMO and WMO research, of course. But I must say, I was very happy with their way of acting. Speed. And helping us to get it along quite fast. So within a few days, but still we had to do an extra round of questions, and they answered once again within 1 working day. So I think that was very helpful. And I hear the same stories from other METCs in the country. Yeah. So that's about the privacy issues. And another question is from, let me see, how many patients recover very slow? Can Zorgdomein help illustrating their trajectories in primary care? I think Joe Muris asked that question. Well, I think at present, within our data set, we can't look at, let's say, we can see the recovery of patients for those patients who are actually intensive care or palliative care and who didn't, of course, die. But I think if we look at, I would say, normal COVID-19 patients who visit GP practices or corona practices within this time frame, and we have to see it at a slow recovery, which is quite a topic now, with people having fatigue and people having dyspnea for a long time. I think we need other systems for that, and I think our national, or let's say our regional registration databases can be very helpful for that, like Nival has, like Nijmegen and Maastricht both have. I think they can actually find out how big the magnitude of that problem is. We only focus, let's say, on, I would say, the vulnerable people. So, yeah. So I think that's, and there's a third, last question.
Yeah.
And I'll just take that because I got that via WhatsApp. We do it very interactively. And that's Mark Bakker saying, a slideshow showed that the mean time from symptom onset to death was 8 days. How was the date of the first symptom onset determined? That was actually determined based on what the GP told us. So, I mean, there might be some reporting bias in there. And of course, there can also be some patient delay before contacting the GP. But because these are vulnerable people, most GP, let's say medical records will have that in their medical record. And we asked the GP what was the first day of symptoms. So we think that's quite about right. But of course, also there, that's based on the reporting of the GP, so not the patient. So most probably when the GP visited the patient for the first time, they will have recorded symptoms for 3 days or for a week or whatever. But what we see, especially in COVID-19, is that people get symptoms and they deteriorate anywhere between 9 or 13 days or not. And that happens in hospital, but also happens at home. So these were some of the questions I got. Yeah, and I promise you, if you send me any other questions, I'll be happy to answer them
maybe
the rest of the day.
Maybe we have some time at the end of the symposium also to answer the other questions. Then we will switch over to the last part of our symposium, and that is a session about COVID-19 research within the different care institutes. You have seen one example that Jochen just displayed, but we have many research projects going on in the 4 different research institutes. So Professor Cordula Wagner, she will kick off, and she will give the first presentation of what kind of research Nival is involved in. We know that Nival is involved in many research related to RIVM, so you see that quite often. So Cordula is at home, and we welcome you, Cordula. So please, can you tell us a little bit more what kind of research is going on in the Nival Institute?
Thank you, Anna. Yes, I will. And I will give my presentation together with Mariette Heuveld. She's one of the senior researchers at Nival on the surveillance. So I will start and kick off with a broader part of our research program. And I hope you can see this one. Yes. Okay. So thank you. I'd like to start because we only have a couple of minutes. So over the last 2 months, Nival has developed a COVID research program, and basically we wanted to make use of our rich and unique research infrastructure, and of course, like a lot of others, to help understand the spread of the virus and its importance and impact on society. So we thought we stick closely to our unique points and the infrastructure, and focused on 3 pillars within the program. And I will go into some details a little bit later on. But first, to give you an overview, it's the first part is monitoring and surveillance of the COVID patients, and that is mainly in GP practices, out of our services, nursing homes. And the last one has just been started, so we're just beginning to get some figures of nursing home patients, and Jochen has mentioned it before, and that is together with Amsterdam University and the nursing home organizations. The results of GP practices and the patients, COVID patients over there, Mayette will go into it because we follow that in a weekly manner with fact sheets and up-to-date numbers from different angles. But that is a very nice example. Maybe you can use infrastructures in periods of a crisis that you can extend some of the data who are coming in regularly. But most of the time it's on a yearly basis. For parts, it is on a weekly basis. And now we could make it more extensive to use it for the COVID pandemic. So the second part of the research program is more on impact on citizens. And a lot of regulations have been given by the government. And over the last week, the lockdown has really been great influence on our everyday life. And now it's loosened up a little bit. And by today, we can do even a little bit more. But it's really important to know how these impacts, the regulations have their impact on different kind of people, groups of people. And we do have some panels of consumers, people with chronic disease, people with disabilities. And within that, we will focus on the specifically vulnerable people or the people with low literacy. So that is the second part where we use the infrastructure we already have to get more insight into how the impact and experience mainly is of the different kind of groups of people in the Netherlands. And the third part is about the resilience, more the organizational part, but also with the professionals, because it's a really, really heavy burden with the crisis and how the work has changed for them and all these impacts. So we do have some registrations of professional GPs or midwives, and we can use them to reach out for GPs, for example, and ask them how they are handling the current situation, the last 2 months, and how it's changing over time, for example. So these are research projects that have just been started. Then to give a couple of examples, mainly on the pillar 2 and 3, because Mayette will go into the monitoring and surveillance part in a couple of minutes. So for 2, it was the main part of the impact on citizens, on different citizens groups, especially. And the nice thing is what you need is, to some extent, to have some information on the groups before the COVID-19 pandemic, of course, and then how they survive, handle, adapt in the situation of the last 2 months and the months that are coming, and maybe for a second wave, for example. So it's a before some information, and after, or during and after. And we mainly use survey to reach out for the experience, but sometimes we can use in-depth interviews. And it's a little bit of a change because we were used to go, of course, to people or invite people to us at Nivel at the office. But now it's all on the distance. And like now we have this webinar. So we do have some kind of focus groups with combinations of citizens, for example, to share their experience, and sometimes, of course, by telephone and video conferencing, these kind of interviews. So you have to get used to it, but after a while, it's amazingly how good it works to some extent. So more specifically, we do have the experience of citizens in a very, very large panel. So more than 12,000 citizens are in that panel on a regular basis. So we can use it at different points, or weekly for shorter surveys or for longer surveys. The acceptance of the regulations, for example, or information needs. Do they understand what the government is asking them to do? What the impact of the social distancing is, for example. So these are a combination of questions and surveys we have started the last two months, and now the first results are coming in, and we are publishing these mainly to spread the results quite fast in fact sheets. And later on, we of course are planning to look for some scientific publications if we can have more the trend of the development in these kind of figures. The same is a little bit for the people with chronic diseases. And there it's really nice that we do know how the quality of life was before on different angles and the physical health and how it is during the crisis and maybe later on. And maybe we can see later on if the unmet needs have been larger because people weren't going to the GP, for example, or to the hospitals when they would have done it before when COVID weren't around us. And the other part is about the experiences of informal caregivers, because sometimes we hear about it that they do have a lot of extra work and it's more difficult to give that informal care because they are giving it to their partner or to their children or whatever it is. But before it was a couple of other people helping as well. And now they are more or less on their own to help their loved ones. And that is much more difficult and has a more mental burden and sometimes physical burden, of course, as well. And the last one in that pillar is the monitoring of impact for people with dementia. And that is also, of course, the caregivers and the people themselves. How do they understand and handle all this regulation, at least partly to stay at home, to have the distance or this kind of thing. So the third pillar is about the resilience of care organizations and the people, professionals working in it. But at the beginning, we saw some changes in GP practices, for example, with the specific COVID locations. We saw some change on our registration in itself. So how do GPs handle this difference and how do they adapt? That's very interesting. And also it is about how GPs feel about all the extra effort they have to make, all the experience they have. And Jochen at the beginning told us a little bit about it because it's very important to look that they have some, of course, stress, fear because masks are not there. All these kind of influencing and how you can do your work and what the burden of the work is, what you are doing, for example. So the other one is then the collaboration in the area, in the different regions we do have in the Netherlands, because there is some difference in Groningen and Brabant, for example. We could see that all the best practices or all the new ideas that stood up is different as well. And we can learn from it to just collect them together and give an overview, for example, on what has happened and how they in the region in itself found different kind of solution for their problems. So if then a second wave is coming or something else, we can build on this experience and bundling it together in nice overviews and lessons learned and learning points. So just to have a look at the clock, and I will go on and give the word to Mayet. Mayet, can you unlock the microphone? Okay.
Thank you, Cordula. So like Cordula said, we use data from NIVO Primary Care database to look at trends of COVID-19 patients in general practices. And we estimated the total number of COVID-19 patients seen in primary care in the whole of the Netherlands. Just briefly, NIVO Primary Care database uses routinely recorded data from participating healthcare providers. The objectives are to monitor health and utilization of health services in a representative sample of the Dutch population. There are more than 500 participating general practices. Cordula, can you show the next slide, please? Because you are, yeah, okay, thank you. You are still in charge. So among those 500 general practices, some 40 of them are called the sentinel practices. In Dutch, the Nivel Peilstations. And they do, among others, the active respiratory surveillance for 50 years already. They collect nose and throat swabs from a selection of patients with an acute respiratory infection. And those swabs are analyzed for viruses by RIVM. And of course, they have always been analyzed for influenza, but since February, all samples are also analyzed for coronavirus as well. Then for some 350 practices, so it's depending on the computer system, the software system they are using. So for those practices, we have weekly data extractions for some 10 years already. And these data are being used for surveillance and monitoring. So for the whole perspective of all diagnoses and symptoms that GPs are registering. So we could immediately use this data to monitoring the COVID-19 patients. However, I think Johan also described it, there is no specific diagnosis code for COVID-19. So the general advice from the Dutch College of General Practitioners is to use the episode text to indicate whether it concerns COVID-19, a confirmed COVID or suspicion of COVID-19. So we used records from a selection of COVID-19 related diagnosis codes, including symptoms like fever or cough. And by using the episode text, we classified patients into clinically diagnosed COVID-19, suspected COVID-19, or no COVID-19. We use the term clinically diagnosed or clinically confirmed because it is broader than the patients tested positive and also include, for instance, patients with COVID-like symptoms from the same household as a patient that was tested positive. Cordula, could you show the next slide? Yes, thank you. So we calculate weekly incidences per 100,000 of the population, but we also extrapolate to the whole Dutch population. And then we take into account the age distribution and the geographic location of the practices of our sample. So here you see two graphs for the clinically confirmed registered patients and the suspected COVID patients. The trends are comparable to the trends observed by the notifications by the municipal health services and collected by RIVM. The cumulative incidence of clinically confirmed patients in our sample was more than 44,000 patients. The total number of registered patients with the suspicion of COVID-19 was some 100,000 patients. So the next slide, please. So we looked, for instance, at the age distribution by gender. And in the Dutch population, that is in the left graph, it is the light blue bars. In the Dutch population...
Sorry, Mariette, may I interrupt you just for a moment? In order to have enough time for the 4 different institutes, could you come to an end with your presentation? That would be great.
Okay, so we looked at age distribution, we looked at differences for urbanization level and, well, other patients' characteristics we can look at. And we update these figures on a weekly basis, and they are published on the NIVO website. So I can finish with that. Thank you.
Thank you so much, Mariette and Cordula. It was great. It's quite impressive what's going on. We already knew that from the NIVO Institute, but thank you so much for giving this presentation. We postponed the questions until the end of this session, so we are going to have the questions, and you're more than welcome to give the questions to everyone. I see at the moment on my screen, I see Professor Judith Prins. Originally I had in my scheme that first Dr. Dionne Krigos would give a presentation. but maybe we couldn't contact her. So would you already be available, Judith, to give your presentation from the Radboud Institute of Health Sciences?
Okay, that's fine.
Yeah.
I was waiting for Dionne Grinkels as well, but I can start my presentation if you want
thank
to.
you.
I'm the research director of the Radboud Institute for Health Sciences, and this is, let me see how I can go to the next slide. This is one of the three research institutes in the Radboud University Medical Center. And during the COVID episode, 64 studies were started in Radboud University Medical Center, new studies and add-on studies. And then on the right, you can see one of the largest studies that was a nationwide study funded by the Bill and Melinda Gates Foundation to test BCG vaccine in healthcare professionals. And Radboud University is joining in that study, and UMC Utrecht is doing this as well. In our own research institute, 36 studies were started. There were many initiatives in medical departments, clinicians who started studies, for instance, in medical oncology, pharmacy, intensive care, medical microbiology, of course. And there were also studies started in the research institutes, IQ Healthcare, Health Evidence, Primary Care, and Physiology. There is a short movie on the COVID research in the Radboud UMC, but it is in Dutch, so if you want to look at it, you have it on the slide, and I will give you now some examples of studies that were started in our own research institute. And the first study is the one of Professor Maria Hapman, who is a physiologist, and she has a cohort for several years of 22,000 persons who join the 4-day marches or running events. And in this large cohort, she approached participants for online questionnaires during the COVID period, and 4,000 people participated. And she was interested if working at home would influence the exercise, the daily exercise of people. So she divided the sample in 3 groups: those working at home, those for whom the work did not change, and people who didn't work at all or anymore. And what she found is that in all 3 groups, the participants had less exercise, so they moved less. And the largest decrease in exercise was found in the people who turned to working at home, and that was a decrease of 20%. And what she also found in the 25% of people working at home is that they slept more. So they slept more and they exercised less. In this study, a follow-up of the sample will be done in the next months, so we will see if this will change over time. Another study in nursing homes in residence behavior was done by Professor Debbie Gerritsen. She sent out an online survey via LinkedIn in April because she was interested in how healthcare professionals perceive changes in behavior in residents. And she had a sample of 284 healthcare professionals. 66% were psychologists in nursing homes, 22% physicians, and the other 12% were other healthcare workers. And what she found on the problematic behavior, and she reported this in in the report you see on the right is that there were both increases in problematic behavior and decreases. And overall, more than 50% of residents had a large change in behavior type. And this all followed the fact that people had no visitors anymore in nursing homes and they only had contact with the healthcare professionals. Debbie will also set up follow-up research, so she will conduct in-depth interviews with the people who were in the sample, and she will continue the online survey. Those were two new studies that were started, and another initiative I will show is an add-on study. Dr. Sita Vermeulen is doing research in bladder cancer. She is an epidemiologist and has a grant in which she follows bladder cancer patients over the years. But she was also interested in, and she is studying BCG, bladder wash. But she was also interested in changes during COVID, and especially in trained immunity. And trained immunity is that the BCG vaccine induces the memory of the immune system and thereby protects against unrelated pathogens and tumor cells. And what I showed you in the nationwide study is the COVID study of Mihai Netea. And there the research question is, does BCG vaccination lower the risk on COVID-19? And Sita Vermeulen is interested in a similar research question in bladder cancer. And her research question is if BCG bladder wash lowers the risk on respiratory infections or on COVID-19 or the serious course of COVID-19. So this is an example of an add-on study in an already ongoing other study. And then there were initiatives to think about new research questions, and Professor Sabine Oertelt is one of the members of the European Commission's 2020 expert group on sex and gender. And this expert group is interested in the impact of sex and gender on COVID-19. And she worked on a case study in which several research questions, new research questions, were formulated. And the aim is to look at, for instance, sex differences in immune responses, in the dosing and sex-specific side effects of vaccines and therapeutics, to look at gender-specific risk factors, for instance, in healthcare workers and caregivers. They are interested in gender-sensitive prevention campaigns, as well as in the gender-specific socioeconomic burden of public safety measures. So it's not only in COVID on new studies, it's also thinking internationally on research questions to continue on in the next years. So these are very different examples of studies that were started. And then there were also other initiatives in the Radboud University Medical Center, like the development and testing of new face shields, because there were not enough masks in the Netherlands, and our innovation center started to develop new face shields, and those were tested in the University Medical Center hospital. And after proven effective, they were implemented and also disseminated in the Netherlands. And there's also a YouTube on this one, also in Dutch. And if you are interested, you can find it, I think, on the intranet. So just to give you an overview of some studies that were started up and conducted in our Institute for Health Sciences. And that's what I wanted to show you.
Judith, it was quite an impressive overview, what you've given, 64 studies. and you gave some very good illustration. We see quite often Radboud UMC, we see in the news related to COVID-19 research. Now we move on to Amsterdam Public Health, and the co-director of APH, Dionne Kriegels, will give an overview of the research, COVID-19 related research from Amsterdam. Dionne.
Thank you, Onno. Let me share my screen with you. Yes, just a second. Good morning, everyone. It is a privilege to inform you about the COVID-19 research performed by researchers from the Amsterdam Public Health Research Institute, also known as APH. My name is Dionne Kriegels. I'm indeed co-director of APH. Now, what is APH's role in times of the COVID-19 pandemic? Well, the COVID-19 pandemic brings the core of public health to a clear and devastating reality. By directly threatening population health and putting healthcare resources under pressure, acute nationwide measures to protect population health against COVID-19 were taken all over the world. Because of the huge uncertainties around the characteristics of the coronavirus, the impact of the disease and instigated countermeasures on population health and well-being, the healthcare system, social cohesion, the economy and other aspects of life is hard to predict. However, it is certain that the impact of COVID-19 is disruptive, takes place in all societal domains, and will most likely last for multiple years. Now, in the acute phase, just after the outbreak of the corona pandemic, clinical trials predominated. Even when the pace of the outbreak is curbed, research is urgently needed on the long-term consequence of the crisis and on lessons for future outbreaks. Now, as APH, we aim to contribute to asking and addressing pertinent questions about the pandemic and its countermeasures, to support development and evaluation of innovative solutions and strategies, and to contribute to the resilience of individuals and health systems. Now, what is our strategy for the coming years in relation to COVID-19? Well, APH explicitly aims to translate and implement our scientific knowledge into local practices and society. Our focus is on responsive healthcare in this pandemic from a societal perspective using multidisciplinary approaches. The many cohort studies in APH cover populations across the lifespan, as well as new vulnerable populations that will be of great value in this effort. Just last week, a number of our cohorts hosted a webinar in which the PIs debated with participants the importance of gathering and analyzing new cohort data and using already existing data from their own and other cohorts to shed light on the pandemic and its impact on, for instance, vulnerable populations. Now, our core values provide a firm basis for joining the worldwide effort to step up to the COVID-19 pandemic, which includes personal engagement in advancing the health of all citizens, respecting social, ethnic, and cultural diversity, excellence, openness, and integrity in everything we do, clinical and societal relevance of scientific efforts, and being a dependable partner as public health practitioners to healthcare providers, decision makers, and communities in our environment. Now, I'd like to illustrate our COVID-19 R&D efforts related to the pandemic by showcasing some of our projects. I don't give you a count because we are every day as we speak developing new researches and publishing on our results. So I just would like to give you a glimpse ordered by the theme. So for instance, our researchers on working on behavior and chronic diseases, they're investigating how corona affects sports in the adult population, but also among children. Our mental health researchers are investigating in multiple projects, for instance, how technological solutions can help vulnerable elderly to overcome social isolation, and what mental health effects of COVID are by performing international comparative studies. Particular attention is paid to supporting the resilience of vulnerable populations. And this is also done from the perspective of societal participation. Now, our global health researchers are developing rapid knowledge and appraisal methods and webinars for guidance developers. They're investigating the impact of the virus on students' health and are working side by side by the international community in the research activity. Our aging and later life researchers are studying and improving COVID-19 registries in geriatric care and are supporting nursing homes to improve their safety practices and well-being inside nursing homes. Now, not surprisingly, quality of care is given a lot of attention within APH research. Researchers are, for instance, investigating preventive behavior and well-being of the Dutch population during the pandemic. They're evaluating public reporting by countries on the pandemic through their media channels. They're also looking into ethical questions related to the fast data sharing. They're investigating the well-being of medical residents and are advancing and improving difficult consultations via telephone and video consultations. Now, our personal medicine researchers are, for instance, investigating the impact of social isolation on vulnerable populations and are researching also, like Judith just mentioned, gender-related issues. And they're also involving their cohorts, such as the twin register. Now, last but not least, this has given a lot of media attention as well. We have the NICE registry at the AMC. So the Department of Medical Informatics has expanded the NICE registry of the ICUs to collect data on COVID patients. And there is more to come. If you look at the Zonenway second wave of research calls, already more than 35 APH studies were submitted, hopefully to be performed. What I would like to stress is that in these times, open research and collaboration across disciplines and countries is more important than ever to manage and evaluate and learn from this global crisis. So the collaborative part of our research, we are giving extra more attention, and most of these research studies are also in collaboration with the other research institute and some of the participants that are probably listening today. Now, on our website, you can find more comprehensive information on some of the projects that I've just listed, and you can stay up to date on our initiatives and also contact us for new research ideas. Thank you very much.
Thank you so much, Dionne. It was a real pleasure to listen to you and to listen to the overview you've given. I just understood that there is some delay because there are problems with YouTube. So the actual program is running 5 minutes before the real program. But now, if you're not here in the studio, it's no problem. But probably will be 5 minutes later than originally planned. So we move on and we go to the last presentation given by Professor Maurice Segers from CaRe Institute here in Maastricht. And we're looking forward to hear about the COVID research, apart from the research that was already mentioned by Jochen. Maurice.
Hello, Onno. Thank you very much. I'm the scientific director of CaRe in Maastricht. I'm presenting from my basement. So let me share my screen as well. Yeah, I think our vision in CaRe for a healthy society for everyone could not have been more important than now. And what I will do, I will give another overview of the research being done in Maastricht, which adds actually to the already very impressive list, I would say, that I've heard from the other institutes. What we see is that many of our researchers, because we are a CaRe and public health institute, are directly or indirectly involved in this COVID pandemic, each from their own discipline, and we also have a few people working really on the front line at this moment. And given that COVID is especially prevalent in the south of the Netherlands, being in this hotspot and CaRe being traditionally very well connected in the region, we have seen that we have been able to and have a fast response and also initiate a few studies. What I will do is I present a selection of the studies, and I try to categorize it, as you can see on the slide, in providing evidence, infection control, quantifying COVID-19 outbreak, and then focus on older elderly people, and then also the road to recovery. We start with providing scientific evidence. What we have seen is, first of all, maybe a change in how papers are published. We see many more preprint journals, for example, fast access to evidence, which I found very interesting. And we have been able to do at least 2 systematic reviews, one from my colleagues Laura Wijnand and Luc Smith, together with Maarten van Smeden from Utrecht, where they did a systematic review on prediction models, 32 prediction models, which is published in BMJ already. And the interesting bit of this and also the other reviews is that we're trying to do fast and good, meaning that we do more living systematic reviews, that we can publish quickly, have open access to the public, but also keep updating that literature. Another example is a systematic review of myself, which we have done with 50 Dutch epidemiologists looking at risk factors for diagnosis, prognosis, and hospitalization and death. Also here, BMJ has expressed interest, and also that we have already published open access via the library of Maastricht University. Now, also in terms of infection control, I would like to mention the work of Christian Hube, our professor of social medicine and infectious disease control, and he also heads the Department of Infectious Disease Control at our Municipal Health Services, the GGD, Zuid-Limburg. And he's a member of our outbreak management team in the Netherlands of 20 experts that advise the government on how to take action on COVID-19. He is also doing cross-border research. One of the projects is on the COVID-19 difference between Germany and how the spread from Germany goes into the Netherlands via the first nursing home that got affected in the Netherlands. And the other one is a cross-border comparison in the region Maas-Rhine, that's Belgium, Netherlands, and Germany, and how the different measures in the different countries have an effect or do not have an effect on the different infections we see, and also the characteristics of those social networks. So that will be a study among 15,000 civilians. Here we have some pictures of Christian Hube in action. We have a picture of Jochen in action. So I'm not going to talk about Jochen's project anymore. But in terms of COVID-19 quantified, we have also contributed to quantification of the incidences and also the clinical course in nursing homes. Professor Jos Scholz, professor of geriatric medicine, has been one of the leaders in that, together with, and that's, I think, also something we see now a lot in this area, fast collaboration between many partners. So I have to mention Dutch Association of Elderly Care Physicians, Virenzo, University Network in Amsterdam, and also, of course, also the different nursing homes. When we talk about older people, we also see that coronavirus is hitting the elderly people the hardest in every aspect. Not only do they die more, do they get the disease more, also the impact is quite hard. And at the request of Ministry of Health, our Living Lab started an inventory